hopefully you had a nice tea after that very stimulating initial morning bit of the present and the future of diabetes mellitus type 1. So now we go to another very important part of this pre-lunch period, that is the panel, that is the keynote lectures, and it's my privilege and pride to invite the two chairpersons, both of whom needs no introduction in Calcutta and across India. Professor Shubhankar Chaudhary, sir, if you can take the chair. He is, as I said, needs no introduction, a doyen in endocrinology, professor and HOD of endocrinology in our premium postgraduate institute, the SSKM. And along with him, we have our own, very own, Dr. Subrata De, who I am very sure needs no introduction to this group. So, sir, if you can also take the chair and initiate this very important session on the keynote lectures. Thank you very much.
Welcome back. We are absolutely on time, and I think the importance is we'll continue to be on time. Now, these are all keynote lectures. There will be not much room for discussion, but we will follow the 25 plus 5 mode where 5 minutes may be allowed, but we will make sure the presentations don't run beyond the stipulated time. So, but before I begin, I want to introduce Professor Shubhankar Chaudhary, because his title slide is there, but they haven't focused it. So, Professor Chaudhary is actually from SSKM Hospital, and he is really Calcutta's pride in adult endocrinology. He's a great teacher and researcher, and we are very happy to have you with us. A big hand for him, please. About myself, there is nothing to say except stay calm, work hard, and relax when you can. Now, I will introduce the first speaker, Professor Lars Savendal, who's come all the way from Karolinska. And his flight got in today at 8 a.m. He's just freshened up and he's ready to roll. He's our first speaker. The current thing is molecular diagnosis. Is it now something which we should be looking at? So, Professor Lars.
Thank you for a very nice introduction and inviting me here to come to Kolkata. First time here, I really enjoy it. So the question is molecular diagnosis necessary for short stature patients? These are my disclosures. And before going into this topic, I will just show you where I come from, Stockholm. These are the 3 hospitals where we have pediatric endocrine clinics in Stockholm, and I share my time in between. I will start with a case which I had a few months ago. It's a 12-year, 10-month-old boy, both parents of Swedish origin, no consanguinity, both parents of average Swedish height, and the father was late in puberty, and the mother had menarche at 13 years, 6 months. Pregnancy delivery was uneventful, birth characteristics as well, and he had a normal development and no health or school problems. Upon physical examination, he showed no dysmorphology. His height was at minus 2.6 SDS and his weight minus 2.4 SDS. He is still pre-pubertal at age 12 years, 10 months, and his bone age is almost 2 years retarded. And when looking at his growth chart, you can see that he slows down and he keeps on growing along his pre-pubertal growth rate. which is clearly below his midparental target height. So the question here, what is the underlying diagnosis? And could genetics help us here? Should he undergo genetic screening? Think about this. I will revisit the case in 10 minutes. So first, what are the main diagnostic groups being referred for short stature? Usually we divide patients into those with a primary growth disorder, and among these we have those with clinically defined syndromes like Turner. We have the skeletal dysplasias and heterozygous mutations in some associated genes, for example SHOX and the ACAN mutation. I will come back to that. And we also have the third group here of small for gestational age with failure of catch-up growth. The next group, the secondary growth failure, which is often caused by malnutrition, organ failure. It could be growth hormone deficiency, hypothyroidism, or endocrine disorders of any other kind. It could also be organ systems that fail, kidneys, heart, lung, bowel, iatrogenic, or psychosocial. And finally, we have the idiopathic short stature, which is a quite large group of patients where we have familial short stature, we have the non-familial short stature, and we have those with a normal pubertal onset and those with a delayed pubertal onset. My favorite organ is the growth plate. That's what I have spent my last 25 years doing research on, and this is where everything happens, and many of the mutations that affect growth, they directly affect the growth plate. On the left-hand side here, we can see the intrinsic signals. Sorry, it's not possible to. We can see the intrinsic signals here. We have the chondrocytes, we have the extracellular matrix, and we have the paracrine signals. Much of this is genetically regulated. From outside here, we have the causes of secondary growth failure, the endocrine signals, malnutrition, inflammatory cytokines, and extracellular fluid. And altogether, this is the most common reasons for a growth failure. So, what is the role of different genetic variants when it comes to determine final height? We published this review a few years ago in Nature Review Endocrinology, and it's not possible to point here, but you can see at the top here, if you have a gain of function of many of the genes expressed in the growth plate, this will result in tall stature. Here, this one is better. If you have a loss of a less severe or a severe loss of function mutation, you can get isolated short stature or even a skeletal dysplasia if it's a severe loss of function mutation. So this is a continuum. So what genes are involved in the growth hormone IGF-1 axis that can be mutated? If we start from the top, we have disorders of the pituitary development. You can see the most important genes here. We have hypothalamic defects of growth hormone secretion. We have the genes and receptors here. We have the pituitary, where we have pituitary defects of growth hormone synthesis or secretion. Or we could have growth hormone insensitivity, for example, the STAT5 mutation or mutations of the growth hormone receptor. Then we come down to the target organ or the periphery, where we can have IGF-1 resistance, we can have ALS deficiency, primary IGF deficiency, or we can have a deficiency of PAPA2, which is the enzyme that cleaves the tertiary complex and makes IGF-1 free. So, if we, this paper analyzed 107 patients with growth hormone insensitivity, and the aim here was to find out how frequent is a genetic diagnosis in patients with growth hormone insensitivity. And the results show that almost 50% of the patients had a positive genetic diagnosis, where the most common one is a growth hormone receptor mutation in 32% of the patients. And a low height STS and consanguinity was highly predictive for identifying a genetic defect. So the shorter you are, and of course if you have consanguinity, the risk is very high for an underlying genetic cause. So then comes the question, how genetic is height? Well, it's a highly genetic trait. And I don't know if you can see this graph, but the top panel here is the additive effect of genetics. It goes from 0 up to 1.0, from birth up to 19 years of age. And both in boys and girls, the older you get, the more important genetics is to determine height. Almost up to 80% of adult height is genetically determined. Environment is important during the first years of life, but the older we get, the less important environment is. So, what genes are we talking about? There are a large number of genetic variants that explains the heritability for adult height. And this paper with Andrew Dauber, first author, published in Nature Genetics a few years ago, showed that 60% of adult height is heritable. But it's not only one gene. Among these 60%, there were 697 variants clustered in 423 loci. So there is a lot of different variants that contribute to 60% of your adult height. So when we come to different underlying diagnoses, this is a paper which focused on patients born small for gestational age without an identified cause of short stature. And here they found a high yield of genetic variants in those patients where there was no clinical clue of an underlying genetic diagnosis. It was 8 out of 55 patients who had an underlying genetic cause of short stature in SGA patients. I talked about aggrecan gene or ACAN mutations in patients with idiopathic short stature. This is a relatively new diagnosis or a new mutation discovered by Andrew Dauber and Ola Nilsson from Stockholm. And today we know, when studying a large number of families with idiopathic short stature, that more than 1% of patients indeed have an ACAN mutation. So what should we look for when we try to identify such a patient? Well, most of the patients have an advanced bone age and short stature, and end up pretty short. FGFR3, you all know that an increased FGFR3 signaling inhibits bone growth, for example, achondroplasia or hypochondroplasia. And this is the signaling pathway involved. The CNP signaling pathway blocks this FGFR3 effect. And today we know that there are numerous mutations described in both the FGFR3 signaling pathway and CNP. And I will give you a few examples. This is a quite recent paper describing a novel variant of FGFR3 which causes proportionate short stature. There was no abnormalities except familial short stature in this family. This is another family or two families with CNP mutations that cause autosomal dominant short stature. You can see the growth chart here in one of the patients. So why is this interesting? Well, because we today have clinical trials quite far, phase 2 and phase 3 trials on both drugs that interfere with FGFR3 signaling. There is a soluble FGFR3 decoy receptor that can block this pathway. And there is also a trial on vasoretid, which is a neutral endopeptidase-resistant analog of CNP, which can block the CNP signaling and thereby, it can stimulate the CNP signaling and thereby block the FGFR3 effect. So then comes the question again, is molecular diagnosis necessary in, I would reformulate this, in the vast majority of patients with short stature? I showed you some examples here where genetics is instrumental to make the diagnosis and could potentially open up for new treatments. But in the majority of patients, is genetic screening then really of value? Coming back to the case I started with, where we had a father with late puberty. The mother was a little bit later than normal. Patient is prepubertal and has a retarded bone age. And as you can see here, his growth follows the prepubertal growth curve. The diagnosis in this patient, I think you all hopefully agree that this is a case of constitutional delay of growth, a quite common case in our clinics. And I think we hopefully all can agree that genetic screening is not recommended in a patient like this. This is another paper from Cincinnati, Philip Bacalhaud's group, where they examined more than 1,300 patients' consecutive short stature referrals in Cincinnati. And they identified 235 patients with a height of less than the third centile, with a negative history and review of systems and a normal physical examination. And what did they find? Well, they found that in these 235 patients, almost 99% had no pathological diagnosis. And of these, you can see 20% familial short stature, 40% constitutional delay of growth and maturation, and 36% idiopathic short stature. Only 1.3% had a new pathological diagnosis, a celiac disease, and a couple of other patients here. So overall, nearly 99% of patients were diagnosed as possible variants of normal growth. And the screening cost for these patients was $105,000 US dollar per new diagnosis entertained, which really questions the value of wide screening of patients with idiopathic short stature. So, why is molecular diagnosis of no benefit for the vast majority of short stature patients? I think, first of all, in most cases, a single variant or two recessive variants in a single gene are not the sole determinant of an individual's height. And secondly, genetic testing is identifying a variant that may contribute to the individual's short stature, but it is often difficult to say to what degree it contributes. And today, our current knowledge is extremely limited with regard to how multiple variants interact in the same or different growth-related pathways. And finally, almost nothing is known about gene-environment interactions with regard to short stature, especially on the level of individual variants identified on genetic screening. And furthermore, I believe that most often the results often raise more questions than they provide answers. And if one is able to identify a genetic variant that is likely to be making a major contribution to patients' short stature, the next question becomes, what can and should we do therapeutically? And as with all diagnostic testing, the yield of genetic testing will vary significantly based on which patients we select for testing. And finally, currently, there is no good evidence to support definitive selection criteria for patients who should benefit from genetic screening. So, who are not recommended for genetic screening? First of all, the patients I presented. Patients suspected of constitutional delay of growth, often boys, growth and puberty, with a normal predicted adult height, unless there is a strong suspicion of a monogenic disorder. And in patients who have a moderate short stature and the child's stature is within 2 standard deviations of the mid-parental target height, it's likely a polygenic short stature, and then we cannot recommend genetic testing. Furthermore, in individuals with 2 short parents and a height below -3 SDS, unless additional features suggest an underlying genetic etiology. Who do we recommend genetic testing in? Well, I think that genetic testing can be recommended for those individuals for whom the clinician has a degree of suspicion for an underlying genetic alteration at a single locus that is playing a major role in their short stature. And what factors should we look for? The likelihood for a monogenic cause of short stature increases in those patients with severe growth hormone deficiency, multiple pituitary hormone deficiency, and where there is a clear growth hormone insensitivity. I also believe that patients with SJ who do not show a catch-up growth, they deserve genetic testing. As I showed earlier here, a quite high proportion of them indeed have an underlying genetic mutation. Furthermore, congenital anomalies or dysmorphic features is a good reason for performing genetic testing. And of course, if there is an evidence of skeletal dysplasia, or also if there is an intellectual disability, this could be a reason for genetic testing. In a case with microcephaly, where you can't find the underlying diagnosis, genetic testing could be of value. And finally, in those patients with height below -3 SDS, unless parents are short. This is a debate, and I don't know if you attended the recent ESPE meeting in Vienna. There was a debate session where I had a debate with Andrew Dauber, who is the main author of a couple of these papers I review here, and I then presented this slide, which is actually a quote from Dr. Dauber's very recent paper published early this year with this title. And what Dr. Dauber there writes in his paper, I cite him, is that when applied in clinical practice to the setting of short stature, there are many variants that will be classified as having uncertain significance or being likely pathogenic but lack definitive evidence for causality. He also writes, with limited ability to interpret segregation data, it will be difficult to determine whether genetic variants found through routine clinical sequencing are truly pathogenic or simply innocent bystanders. And I think this very much supports what I said before. Genetic screening is not recommended in the vast majority of patients. Dr. Dauber further writes that he asked himself, when should genetic testing become the first line evaluation for children with growth disorders who are otherwise healthy and do not manifest any other clinical signs of hormonal deficiency. To answer that question, he believed that well-designed studies are needed that compare the cost-effectiveness of standard medical evaluation versus genetic testing for evaluation of short stature. And finally, before embarking on these studies, we must first grapple with the question as to how we will define a causative mutation in a child with short stature. So some clear advice here. When could you consider and when will there be a benefit of genetic testing? Of course, everything depends on what situation you're working in and what what you can manage. This is the final slide here. So this is a list of different, you can read it yourself, benefits of genetic testing. And the final slide is here. What patients should we select for genetics testing? First of all, families with severe forms of short stature, especially if there is a consanguinity, when we have syndromes, multiple pituitary hormone deficiency, severe short stature, disproportion, skeletal dysplasia, SGA, and of course, a girl with short stature with unknown etiology. We should never forget a Turner syndrome. And by that, I'd like to thank you very much, and I hope we are a little bit wiser.
Thank you very much.